Hello, my name is Danielle Mee, and this is my Capstone final presentation for Capstone in Advanced Clinical Practice. Social work is an essential profession that focuses on individual well-being in a social context and the well-being of society. Without social work, society would be in a dire crisis of care. Those who are vulnerable, oppressed, and living in poverty would be at the center of the crisis. Social workers support those individuals, families, and communities through various services. One of those many services provided by social workers include therapeutic services. The purpose of this presentation is to demonstrate knowledge gained during therapy-based practicum placement. It will highlight the application and integration of knowledge learned through real-world experience. The presentation progression consists of two sections. The first section will focus on the engagement, assessment, intervention, evaluation, and conclusion of a specific case followed by the social worker. The second section will highlight issues faced within three separate categories, which will be elaborated more in Section 2's introduction. Knowledge of practice context was used to engage with client systems. Social work practice context involves understanding and applying knowledge of human behavior and the social environment to engage with individuals, families, groups, organizations, and communities. This is done by using a person and environment framework. This case was viewed with the lens that the health of the client could not be understood without consideration of the environment as a factor. The social worker considered the family and how the family shaped the client's well-being and understanding of their environment. Social workers should value the human relationships their clients have with those in their environment and the relationship with the environment itself. Understanding theories of human behavior and the social environment is important to critically evaluate and facilitate engagement with clients. The human behavior and social environment theories learned within the social worker's coursework were utilized and applied when working with this client and the client system. To protect the client's confidentiality, they will be referred to as MV or the client. MV at the time of treatment start is 8 years old and will be 9 by the end of treatment. The client is of Caucasian descent and a male who uses he/him pronouns. His primary language is English. The client currently lives in California with his adoptive family in a single-family apartment who is of Caucasian descent and speaks English as well. The adoptive family includes his mother, father, and 2 younger brothers, ages 1 and 6. The brothers of the client are both from the marriage of the adoptive parents. The client was referred to Homestart Behavioral Health by Rady's Children's Hospital, a major nonprofit pediatric care and research center located in San Diego. Homestart is another nonprofit in San Diego that specializes in child abuse prevention and offers treatment on both individual and family levels. The reason for evaluation is that upon referral and completion of Homestart's eligibility form, the client had qualifying traumas for treatment that include neglect and witnessing domestic violence from his birth family. The presenting problem as reported by the client's adoptive mother is that the client has periods of explosive behavior, including screaming, yelling, and throwing objects, often directed at his 6-year-old brother. The behavior spikes around the client's birthday as well as their adoption date. Given the age of the client, the initial intake was completed with at least one parent. Prior to the initial intake being completed, confidentiality was reviewed with the caregiver. It is important for social workers to remember that confidentiality, as well as its limitations, should be discussed with clients as soon as possible, as outlined in the Code of Ethics. In this specific case, the intake history was completed by therapist and adoptive mother. Based on the intake history and information provided, the history of explosive behavior began prior to official adoption in 2021. Explosive behavior could be seen at the previous foster placement, but due to no contact with the birth family, it is unclear if the client exhibited explosive behavior at any of the client's siblings within the birth family or within the home at the birth family. It should be noted as well that this behavior only occurs in the client's home and does not occur at school or outside activities. The client has received therapy services prior, but has never been prescribed any medication while in services. It has been evaluated that he is not a risk of harm to himself or others in the future. Client and caregiver were informed that if this changes, the therapist is a mandated reporter, and per the Code of Ethics, The client's rights to self-determination may be limited if the social worker's professional judgment deems the client a harm to themselves or others. Additionally, the client has had no major surgeries, illnesses, or extended hospitalization outside of one minor concussion where the client had to stay overnight. When looking at psychiatric history, it is important to remember that family psychiatric history can impact the client. People are their family's history. They're not simply a product of themselves. They are comprised of the world around them and the one within. Salibi suggests genetics has the potential to play a role in future psychiatric or medical conditions if they arise within a client. Although it is unclear if this applies to the client as there is not a lot of information from MV's birth family. The therapist is only able to find out information about birth family through the current adoptive family, who has no contact. MV does not have a personal history of substance use or abuse. However, there is a history of substance use and abuse within the client's birth family. Once again, both the individual and their environment are multidimensional, and these dimensions can influence behavior according to Hutchinson. If there was substance use during pregnancy, there may be a connection with MV's behavior and reason for referral. According to Cooper and Lester, personal history should be included in developmental history. Developmental history includes milestones, birth, and prenatal care. Little is known about MV's prenatal care and birth, but he achieved all developmental milestones and within normal timeframes. Client appears as their stated age and as a Caucasian male. They have an average gait for an 8-year-old with appropriate coordination and no notable movements. He appears of average build with appropriate grooming and dresses for casual. MV often presents in athletic clothes that are always appropriate for the weather. Appearance is majority open, cooperative, and engaging. Speech is always clear, coherent, and spoken at a normal rate. Eye contact is often good and, depending on the activity, can be sporadic. As for mood and affect, it is typically euthemic with normal variation in intensity. Client is always oriented to place, time, and situation. Intellectual function is average and is above average with reading. Vocabulary and cognitive function is as expected as a child of his age. Thought processes for client are often coherent with the occasional flight of ideas. Thoughts can be goal-directed and can also not be at times. Thoughts are often well-connected but can sometimes include loose associations. They present with no false perceptions or delusion in thought processes. Client exhibits good judgment and insight for a child of their age. Impulse control is good, but there are times when behavior implies they are not thinking about their actions prior to completing them. The client completed the Child Depression Inventory 2nd edition and the Trauma Symptom Checklist for Children. The CDI-2 is specific for evaluating a client's depressive symptoms, which is a self-report that contains 28 questions. The TSCC measures trauma-related symptoms from a self-report's perspective. The caregiver is asked to complete the Child Behavior Checklist, Trauma Symptom Checklist for Young Children, and the Parenting Stress Index short form. The CBCL gives the caregiver an opportunity to answer questions that will assess their child's problems behaviorally and emotionally. The TSCYC measures the symptoms related to the child's trauma and abuse. It consists of 90 questions answered by the caregiver. The final assessment filled out by the caregiver is the PSI short form. This is an assessment that measures the caregiver's stress levels with their child, used to identify where stress is originating while looking at the child-parent characteristics as well as potential situational stress. The foundation of the strategies and interventions for this case are based on the results of assessments from client and caregiver, as well as their preferences for outcomes and the use of an evidence-based practice framework. The results of the assessment solidified that the explosive behavior needs to be reduced through intervention, which was the caregiver's preference for treatment. The assessments indicated that the client is experiencing mild depressive disorder symptoms that require intervention. The social worker checked in with the client regarding the results, and the client expressed their preference in including improving their confidence as a goal in treatment. Social workers should use evaluation and research evidence in their professional practice by critically examining and keeping current with emerging knowledge per the Code of Ethics. Considering this knowledge, the therapists use consultation with a licensed clinical social worker and research about trauma-focused interventions to select the appropriate method. The intervention being used with this client is trauma-focused cognitive behavioral therapy and trauma-focused integrative play therapy. The rationale was primarily based on evidence-based practice principles. TFCBT is an intervention that has copious amounts of support from practice-based evidence and is widely known as an effective treatment for children who have experienced trauma, according to Goodyear-Brown. TFIBT incorporates elements of evidence-based practice such as TFCBT alongside expressive therapies such as arts and sand therapies rooted in psychoanalytic theory, and there is a wide variety of research to back their effectiveness when working with children, according to TFIPT creator Dr. Gill. The social worker thought it best to integrate the two together for inclusion of directive and indirective play therapy methods tailored to the client. The selection of TFCBT and TFIPT can be better understood through family systems theory, which looks at the family as one emotional unit rather than the collection of individuals. The client in this case is a product of two separate family units. Within his first family unit, he experienced social dysfunction in the form of different types of abuse. The explosive behavior developed by MV is a result of living within this family system. He then moved from a low-functioning couple to a higher-functioning couple. As a result, MV has a moderate differentiation of self, which means his self-esteem is based on feedback from others. Looking at MV's self-esteem through a family systems lens, it is due to negative feedback from his now sibling age 6, according to Keller and Noon. Considering the case from a family perspective, interventions should be selected that include the family system within the phase of treatment. Both TFCBT and TFIPT incorporate family involvement as a central component of the treatment process. All strategies taught to the client will also be taught to the caregiver with consideration given to the family as a unified system. These skills are intended to support not only the client's progress, but the caregiver's ability to reinforce and implement them within the home environment. Goals of the treatment plan include a decreased conflict with sibling, reduction of mild major depressive disorder, F32.0 criterion met, and the processing of past traumatic memories. The goals were created by information provided in an initial intake with caretaker and the criterion that was met for mild major depressive disorder. The problem of low self-esteem and worthlessness will be met with the goal of reducing negative self-talk. The problem of explosive behavior will be met by addressing the goal of reduction in conflict with brother. Processing traumatic memories experienced within the client's past will also help address explosive behavior. Objectives related to the identified problem and issue of explosive behavior and criterion met for mild major depressive disorder include developing coping skills, addressing past experienced trauma, and developing healthier cognitive patterns. The first SMART goal of the treatment plan is that MV will develop 1 to 2 coping skills by the end of treatment for the purpose of reducing conflict with his brother. Second, MV will develop more healthier cognitive patterns by the end of treatment for the purpose of reducing negative self-talk and low self-esteem. Finally, MV will attend and participate in play therapy to reduce behaviors by the end of treatment for the processing of unresolved feelings around his traumatic experiences. A core competency within social work practice, according to the Council on Social Work Education, is to engage with clients to critically choose and implement interventions to achieve their goals. To enhance the capacities of the client system, the treatment plan was created alongside both client and caregiver, engaging both directly to define the goals of treatment. The social worker regularly checked in with both the client and caregiver to assess effectiveness, fostering ongoing mutual evaluation and adjustment. The social worker developed mutually agreed upon goals and objectives through shared decision-making. Social workers should seek to understand and involve families when planning potential solutions according to the standards for social work practice and child welfare. After collaborating with client and caregiver to find mutually agreed upon goals and objectives, the social worker then collaborated with the behavioral health team at HomeStart. To negotiate, mediate, and advocate on behalf of client systems, social workers should incorporate culturally responsive methods. The social worker in this case recognized the client systems as experts of their own lives and culture. The social worker recognized that cultural experiences of clients may impact their worldview and help-seeking behaviors. Therefore, when working within this client system, active listening, cultural humility, and honoring client perspectives were utilized alongside shared decision-making. To facilitate effective transitions and endings that advance mutually agreed upon goals, the social worker continues to update the client and caregiver about the ending timeline and continuously reviews progress with both client and caregiver to help them recognize their accomplishments. Data was collected from individuals within the family system using both qualitative and quantitative data. Qualitative data seeks out understanding of lived experiences, while quantitative data seeks to understand through numerical value and comparison, according to McGowan and Botter. The listed assessments seek understanding of lived experiences, making them qualitative assessments. Scoring the assessments creates quantities assigned to the data outcomes. After the data was collected, the social worker scored the assessments to critically analyze and interpret everyone's response. Results from the TSCC and TSCYC were compared against each other to see the difference in interpretation of trauma symptoms between client and caregiver. The assessment results were discussed with caregiver and client to further the collection of qualitative data. The mixed method was selected to create a more complete understanding of data to address the target problems. Ongoing evaluation is fundamental to social work practice, as practitioners are expected to continuously assess the effectiveness of treatments and interventions and adjust when necessary per the Council on Social Work Education. The selected assessments support this process by providing structured measures that facilitate continuous monitoring and evaluation of practice outcomes. The initial assessments were given prior to session starting. The same assessments were given at the midpoint of treatment and will be given at the end of treatment. The CDI is scored by hand, while the other assessments are scored using software specific to the assessment. The evaluation design follows a trauma-focused integrated play therapy model. According to Dr. Gill, the three-phase model of treatment is establishment of safety, processing traumatic material, and social reconnection. The strengths within the client system are that the client is responsive and fully engaged in therapy services. The client and his caregiver have open and honest communication not only amongst themselves but with the social worker as well. A challenge within the client system is the sibling's behavior and level of involvement in conflict with the client. To address the challenge, the social worker has open conversation with the client system about engaging the sibling in intervention alongside the client while in the closing phases of treatment. Per the standards for social work practice and child welfare, it is important for a social worker to actively engage the family to ensure its well-being as a unit, and inclusion of the sibling will help achieve this standard. The needs within the client system are the behavioral health services they are currently receiving, services for the other sibling which the family is in the process of connecting with, and empowerment. The client developed coping skills that worked for them and aided in reduction of conflict with sibling, as reported by caregiver and client. Additionally, scores regarding aggressive behavior, interpersonal problems, anger, oppositional defiance, and difficult child decreased as shown in the figures in this slide and the next. MV developed healthier cognitive patterns reflected in the decrease of depressive symptom score shown in these figures. Results from the PSI short form indicated an apparent increase in reported difficulties. After consultation with the clinical supervisor and discussion with caregiver, it was determined that this increase likely reflects greater honesty and openness in the caregiver's responses during the second assessment rather than an actual worsening of functioning. Overall, the target problems showed improvement over the course of treatment as reflected in the comparison between the baseline assessments. Evaluation findings were used to improve practice effectiveness by adjusting interventions when needed. If assessments or feedback indicated that an intervention was not working, it was changed. The basis for this conclusion of using evaluation findings to adjust treatment when needed is theoretical. The social worker used their knowledge of human behavior and person and environment to evaluate outcomes as well as practice effectiveness per the Council on Social Work Education. HomeStart, the field agency for this case, evaluates its practice through several formal and informal processes. The agency undergoes an annual audit due to grant funding requirements. Internal evaluations are also conducted during behavioral health team meetings where staff review practices and discuss service delivery. Clinicians also evaluate their own practice through assessments administered at the beginning and end of treatment, with mid-assessments being encouraged but not required. However, requiring mid-assessments could strengthen the process by allowing for more consistent monitoring of client progress and a more comprehensive evaluation of treatment outcomes. This section of the presentation has discussed engagement, assessment, intervention, and evaluation of one singular case. The presentation allowed for the social worker to better understand and evaluate services provided to clients that contribute to individual well-being in a social context. The core competencies of social work were better understood by the social worker through this assignment, as well as the context in which they are applied. The second section of this presentation will address experiences related to ethical, human diversity and social justice, and policy issues. During my internship, I encountered an ethical dilemma related to social workers' ethical responsibility to clients, specifically stating that social workers should take reasonable steps to avoid abandoning clients who are still in need of services. I had been working with the client for a relatively short period of time when they disclosed information indicating they were a risk of harm to themselves. Following the disclosure, however, the client ceased all communication with the therapist. On one hand, I was concerned about abandoning a vulnerable client who was still in need of services because the client was not responding. Though the client had the right to not respond due to the right to self-determination, I also recognize that the Code of Ethics states social workers may limit clients' right to self-determination when, in the social worker's professional judgment, the client's potential actions pose a foreseeable imminent risk to themselves or others. This ethical dilemma between self-determination and abandonment was the result of both my own decisions and attitudes as well as the client's actions. There were certain decisions I made that put me into the dilemma. In reflecting on my role, I recognized that the decisions I made contributed to the situation. The most significant was not consulting with the supervisor immediately after the client's disclosure of self-harm, knowing there was a history of suicidal ideation due to the agency being on a holiday break. This delay contributed to the heightened anxiety and uncertainty surrounding the client's safety. The client's decision to stop responding contributed to the dilemma as well, although the social worker, me, had to respect the client's decision, even if I didn't agree with how they did it. The dilemma impacted my decision-making skills and resulted in a delay of services for the client. Regarding the professional values of social work, I would say that my personal values are similar. It is my belief that I would not have chosen social work if my own values did not align with the preamble of the Code of Ethics. The client does have a right to self-determination, and that self-determination can be limited if they are a harm to themselves. Though that is not to say that ethical dilemmas regarding the self-determination don't occur and they don't impact me on a personal level. This dilemma increased my self-awareness to a certain degree. I realized I have a weakness when it comes to dealing with clients experiencing suicidal ideation and/or self-harm. This weakness influences not only my clients but my own self. I had to work on my emotional self-regulation when working with this client. I maintained professional demeanor in my oral, written, and electronic communication with the parties involved in this case. Additionally, I was able to maintain a professional demeanor in behavior and appearance when in session with the client per feedback from my supervisors. However, after session, my self-regulation was no longer in control. When I first met with my individual supervisor and updated them on my clients, I began with the client I was experiencing the dilemma with. My supervisor asked how I responded in session when the client disclosed information to me. I told them I created a safety plan with them and provided them the necessary numbers for crisis support. I then asked my supervisor for help with next steps, as the client had stopped responding to me. We discussed next steps, and then we discussed my emotional response to the situation. We also reviewed agency policy regarding the client since they were an 18-year-old providing minor consent. I used group supervision in a similar manner to see if the steps I was taking were correct, where I could correct, and what to do next. I did the same thing in admin where I asked the same questions. The admin meeting suggested potentially doing a welfare check on the client. My clinical judgment based on information provided by the client was that I ran the risk of re-traumatizing or endangering the client through police interaction. Following the meeting, I once again turned to my supervisor to discuss the additional dilemma I was facing. While experiencing this dilemma, I thought back to a course that I had taken at the start of my social work journey. The course had to do with the history, philosophy, and theory of social work practice. In the textbook, there was a brief discussion on positive and negative obligations and ethics. The discussion briefly quotes David Sawyer in the paper, The Right to Fail, where he says the right of self-determination includes the right to fail. My client has the right to fail, and I can provide them with resources I believe they need, but I cannot force them to access it. It is their decision to fail, then I must respect it. And if their decision is to stop responding, then I can only do my part in trying to reach them for so long. If calling the authorities did not pose a risk to my client, and I did not hear from them by the third appointment, I would have easily made that call. The human dignity and social justice issue a client faced involves systemic oppression within the criminal justice system. My client had prior juvenile detention involvement, gang affiliation in early adolescence, and multiple charges on his record that significantly limited access to employment and stable housing. I selected this case because it really showed me that I needed to engage in my own research to develop cultural awareness. It is my duty as a social worker to obtain education and demonstrate understanding of social diversity and oppression per the Code of Ethics. According to the Council of Social Work Education, students should learn about their own privilege, power, and personality, and develop a commitment to dismantling oppressive symptoms. This was a case that allowed me to reflect on my privilege, power, and personality. If you look at a demographic standpoint, my client and I differ significantly. I identify as a woman of Caucasian descent in her late 20s. My client, a male of Hispanic descent who had just turned 18. My client immigrated from Mexico after family involvement with a cartel. I grew up and spent most of my life in New England, where I did not face the experiences he did with incarceration and cultural marginalization. Similarly, though, my client and I recognize this system for what it was. We both recognize the structural inequities embedded within the criminal justice system. The similar standpoint allowed for very open and real discussions about client experience. At the same time, our differences, particularly racial, gendered, and experiential, required additional attention. As emphasized by the Council of Social Work Education, I had to actively examine how my racial privilege and educational background shaped my worldview and therapeutic service. The social justice issue of disparities within the justice system impacted how I responded to the client when they discussed their involvement and the impact it was having on their ability to get a job. My client had mentioned falling back on the cartel, and I had to work to find a viable alternate solution. Interestingly, Finley et al. Completed the first research into individuals facing employment discrimination being better off employing themselves than beginning their own business. This finding influenced my engagement with the client and encouraged finding alternative solutions to the social justice issue they were facing. This case evoked significant countertransference. When I first learned about my client's gun charges and cartel involvement, I experienced fear. I worried about my safety and questioned whether he might perceive me as representing the system that harmed him. Reflecting honestly, I recognized a bias. I initially equated criminal history with dangerousness and poor moral character. Despite my undergraduate background in criminology, I found myself holding stereotypical assumptions. Using Hyman's definition of countertransference as encompassing all emotional responses towards a client, I acknowledged that my fear reflected internalized societal narratives about crime and violence. Consistent with the NASW standards, emphasis on self-awareness, I intentionally examined and corrected these biases. As I continued working with the client, my preconceptions were invalidated. He presented as thoughtful, reflective, and motivated to change. The experience exposed implicit biases that require ongoing self-reflection and supervision. Based on sessions with this client, oppression and marginalization shaped the client's life experience. The client identifies as being a Hispanic immigrant, which is a historically marginalized group within the United States. The client faced incarceration, limited employment access, and internalized stigma. They frequently express beliefs that they deserve the negative outcomes happening to them based on the choices they made and who they inherently were. Taking these experiences into account, I had to use a more culturally competent and trauma-informed lens. It is important to recognize how intersecting identities influence access to resources and exposure to discrimination. Human diversity, social justice, and anti-racism, diversity, equity, and inclusion both came up in my supervision about the case. My supervisor and I discussed the need for criminal justice reform and the impact the system has on those involved with it. We discussed this impact and how it disproportionately impacts individuals of Hispanic and Black communities. We discussed my privilege as a white woman and the skills necessary to engage in anti-racist practice, such as recognizing bias, diversifying knowledge, and having these intentional conversations. We had a conversation about different books that I can read and ways to engage in practices that meet social work standards, values, and ethics around cultural humility. There's still a lot that I would change next time, especially my advocacy level, which was limited. The social worker did not engage in macro-level advocacy or connect him as extensively as they could to community-based employment programs. In the future, direct advocacy could be increased by collaborating with re-entry organizations, assisting with record expungement resources where possible, and strengthening interventions. Social and economic justice were advanced primarily through reframing his internalized stigma, validating the systemic barriers he faced, and collaboratively identifying alternatives to criminal involvement. While small in scope, these efforts supported empowerment and self-determination, both of which are core social work values. The Adoption and Safe Families Act was implemented due to prior policies being unequipped to handle the influx of children in foster care during the 80s and 90s. It was created to help increase not only child well-being and safety, but permanence and placements as well. The Act includes substance use treatment and domestic violence assisted within the time-limited reunification services and activities provided to child, family, or both. The original Act indicated further research needed to be done between the connection of substance use and the scope of the problem as related to the child welfare system. The Act impacted the client in a mixed way. There were positive and negative outcomes. The client was removed from his birth family around the age of 2, and at the time of removal is when the termination of parental rights timeline began, based off the Act. The timeline of parental rights being terminated if the child remained in care for 15 of 22 months benefited the client. It led to a permanent placement rather than ongoing reunification efforts and continued foster care placement. The rumination timeline reduced the client's experience of instability at a young age, though this removal had a lasting negative impact on the client as well. The client harbored the lack of connection with his birth family, which presented as behavior issues later in life. The policy may not directly impact the social worker's ability to effectively intervene with this client, since they have already been in a permanent placement. However, it may impact future clients if, like this client, they do not receive services until after placement. This client received no services until well after the placement due to the focus being on placement rather than care. A core competency of the social work profession is to engage in policy practice. This means the social worker identifies policy at different levels that affect several factors, including well-being, human rights, justice, access to services, and service delivery. The social worker in this case engaged in policy analysis of the Adoption and Safe Families Act. Through this analysis, the social worker considered how the policy may have affected the client's past access to services, as well as the potential impact it had on the client's birth family. During the review of the policy, the social worker also identified external influences that may have shaped the development and implementation of the Adoption and Safe Families Act. Although a complete and formal policy analysis was not completed, conducting a comprehensive analysis could provide valuable insight. If such an analysis were developed, then it should be submitted to state legislators and staff as well as government officials. A social welfare analysis was selected as the policy analysis approach due to the resources available. As a student working within an agency that receives government funding, the social worker is in a position that provides access to information and organizational support that could facilitate a thorough policy analysis. This position allows the social worker to examine how policies influence service delivery and client outcomes while utilizing the resources available through the agency to support a comprehensive review. The clinical judgment of the social worker is that an analysis needs to be made to bring the competency of engaging policy practice. If a complete analysis was completed and submitted to the correct parties, the policy practice would need to be evaluated. Part of the analysis is assessing alternative policies. In order to evaluate the effectiveness of the policy, the alternative would need to be implemented and monitored. In this case, that was not pursued. The primary reason is that the client has already achieved permanent placement and is no longer directly affected by the policy. Because the Adoption and Safe Families Act places a strong emphasis on achieving permanent placement, there may be opportunities to improve how the policy serves families and children in the future. There is room to consider policy amendments that better advance human rights as well as racial and economic justice. If limitations were not a barrier, several improvements could be explored. One potential change would be introducing greater flexibility in reunification timelines. The Adoption and Safe Families Act implementation was aimed at reduction of time spent in foster care, which can be due to longer reunification efforts. However, the length of termination of parental rights could be more flexible, especially in the case of substance use disorder involvement. Additionally, when looking historically at the Adoption and Safe Families Act implementation, it followed the war on drugs, which brought about anti-drug policy acts. These acts increase the number of mothers incarcerated and involved in child welfare. The Adoption Safe Families Act was enacted in part due to counter the increase of foster numbers due to the anti-drug policies, according to Phillips and Mann. It is a well-known fact that the war on drugs impacted marginalized communities more directly due to racial and income inequalities. To change this policy, the social worker and members of the social work community must advocate for anti-racist and anti-oppressive policy practice per the Council on Social Work Education. In summary, this section has discussed a case in which the social worker experienced an ethical dilemma and was significant regarding a human diversity and social justice issue. Additionally, it discussed how social policy impacted another client within their life. All in all, this section of the presentation allowed me to reflect on my own social work practice. I was able to analyze my work and see both areas of strengths and weaknesses. I grew as a social worker in practice settings by applying and expanding my knowledge in various skills. Thank you for listening to my presentation.